We've been talking about the concepts of complete dentistry, and what I want to do is add for you what I believe is the next frontier that we're moving into with dentistry, and that is what we're calling integrative dental medicine. Integrative dental medicine is looking at the dental patient as a whole person and expanding our paradigm to include other things, as we'll show you here. And I'd like to just start by reviewing for a minute what I see as the trends over the last 50 years of our knowledge base and how it's grown. So if you go back to 1968, we might call that the era of dental occlusion. So you had people like Clyde Schuyler and Dr. Sig Ramford at Michigan and Dr. L.D. Pankey down in Miami that were influencing people. If we go to 1978, we move from that era of understanding occlusion to applying it into restorative dentistry. And of course, our own Pete Dawson would have been a leader in that area of restorative dentistry, and periodontal therapy, complete periodontal therapy, began to be engaged during that same time. Let's save teeth for a lifetime. And then the third era here in 1988 was the era of TMJ. We were right in the middle of that era, the era that started in the early 80s and ran on through. In our Dawson Academy, Mark Piper has been a very strong influence on our learning about joints and management of deranged joints. Then in 1998, we would have been right in the middle of the era of aesthetics and cosmetics. I like to give Ivoclar credit for marketing that subject and causing the public to come and ask for veneers and whitening and changes to the aesthetics of their teeth. And that's often how things happen. But that was obviously a significant addition to our profession and an important era. Around 2008, 2007 and 8, we went through an era of global financial crisis. Wall Street, investment banking, big collapse there. And we all know the impact that it had on dentistry. It was a big impact. And so that was an influence for a period of almost 10 years where there has been some effect of that as a result of finances. And then I would like to suggest that now in 2018, moving forward, that we're in the era of integrative dentistry, and integrative dental medicine and digital dentistry obviously is here to stay. So we're looking toward the future now in 2017. I would like to talk about what does this integrative dental medicine model, era, new frontier look like. And so what we've done is sort of divided this into three simple categories. I like boxes where we can remember things and begin to talk about the different factors here. And so one box would be the subject of infection and inflammation, obviously a big emphasis there on periodontal control and its impact on systemic health. Another box or circle here would be airway and breathing disorders. I'm going to give you an example in just a moment of how we evaluate that component of our model. And then TMD and occlusal disorders will always be in the camp of dentistry. So we are the physicians of the masticatory system. And so as a result of that, this will be an area that we should all have some expertise in and be able to resolve or help patients get resolution in their problems. One of my all-time favorite books was by author Atul Gawande, who's a physician, called The Checklist Manifesto. And this was a bestseller. You saw it in all of the airports in traveling, how to get things right. And he points out that checklists are critically important for consistency, for not leaving details out, for getting the results that we want and accomplishing the things that we desire. So with that being true, what I have done is developed a checklist for this integrative dental medicine model. And so here you see that checklist. And what we've done with this is we've divided those three categories that we've discussed into checklists going down the column: screening history, clinical evaluation, screening and testing, and our differential conclusion from that. So we have that for each one of these three important categories. And then the second part of the checklist would be, what are we going to do about it? So now we know that someone has an airway and breathing problem. What are our options? And so we'll talk about that as an example, how we handle that right now. The thing I want you to remember, though, right now in this part of the discussion is that systemic inflammation and infection, airway and breathing disorders, TMD and occlusion disorders are often linked together. And so our paradigm, our model is expanding all the time as a result of what we're discovering, what we're learning, and what the research is showing us. So here we're going to take our checklist and we're going to look at the airway and breathing disorders category. And under that, what we're going to do first is look at the history. So I'm suggesting that you should add to your medical history forms, your medical dental history form, these items if you haven't already. Are you a mouth breather? Do you snore? Have you been told that you have sleep apnea? Are you sleepy during the day? Is your sleep quality poor? Do you have nasal congestion? Do you find yourself in a forward head posture helping you breathe? Tongue tie problems, chronic cough, deviated septum. So these are some good general screening questions for patients that might have airway and breathing disorders. Then as the patient comes in and we see them clinically, we're going to go ahead and do our clinical evaluation. And there's 6 simple things that you can do in less than probably 2 minutes that can help you screen for these airway and breathing disorders. So let's talk about those. We also, if we find positives in these areas, may consider screening and testing using overnight high-resolution pulse oximetry, do home sleep testing, which you can do yourself, or work with someone who would like to assist you in that. The question is it positive or negative for airway and breathing disorders? So let's look at these 6 items just for a brief few minutes. As we look, first of all, a simple thing that you can observe, and you'll be observing this now when you're in the mall and all over, is the fact of neck circumference. So if a patient's neck circumference for a female is 16 inches or greater, for a male 17 inches or greater, that's considered a very high risk for having airway obstruction, around 90+% of the time. And so one question we're going to check negative or positive is the neck circumference greater than 16 inches? Another thing we'll see here is 3 very familiar faces: Tim Russert, a political analyst, Judge Scalia from the Supreme Court, and Reggie White, the famous Hall of Fame football player. They all 3 have a couple things in common. And I hope that you see, number 1, is that they all have a neck circumference of greater than 16 inches, certainly. But the other thing, unfortunately and sadly and tragically, they have in common is that all 3 of these men died of heart attacks in their sleep that now has been associated with a diagnosis of sleep apnea. And it's tragic. This should never happen in today's present world with the diagnostic assistance that we can give through dentistry to screen every patient, which is what I'm recommending that you do. The next thing is the Mallampati score. So if we have the patient upright, open your mouth wide, look in the back of the throat, can you see the uvula? In class 1, you can see it high and dry. Class 2, it's dropping down a little bit. Class 3, it's partially obstructed. And in the class 4s, the uvula is completely hidden because the soft palate has dropped down behind the tongue. And so there's been an association with this type of class 3 or 4 Mallampati with a higher incidence of airway obstruction and sleep apnea. That just makes sense. What I would point out, though, on the Mallampati, as we think of a score of greater than 2 being a risk factor, is that we see patients that are Mallampati 1 that have severe sleep apnea, and we see patients that are Mallampati 4 that don't have any sleep apnea. So this isn't an automatic, but it's certainly a great indicator. Here, for example, we see a patient who their uvula is very visible. I would call them a class 1, but the tonsils are super enlarged and the back of the throat is blocked and the airway is very much obstructed. So you see how that might work. All right, the third thing here that we could look at is scalloped tongue. A scalloped tongue is an indicator of a low tongue, a tongue that's spread out in a box of oral cavity that's too small for the tongue. Not typically because the tongue is too large, but because the box that the tongue sits in is too small. And so that can be a great indicator for a potential low tongue, mouth breather, spread out tongue situation that may be indicative of an airway obstruction. Restriction of the tongue. More and more and more we're appreciating, both in children and in adults, the impact of tongue tie and how important that can be. So if we have a patient open their mouth as wide as they can, then we say, now go ahead and lift your tongue up and touch behind the top of your front teeth with your tongue. If they can only go up halfway, 60%, 50%, 40%, they have a tongue tie restriction, which is going to keep the tongue in the floor of the mouth, immobilize the tongue, and often these are mouth breathers who have more problems with airway and breathing issues. Nasal stenosis, another super easy thing you can do is with your patient in a reclined position, just say, breathe in, and as they breathe in, do you see expansion of the nostril or do you see collapse of the nostril? When you see collapse of the nostril like we do here, and then when you look at the CBCT of that patient, you see complete obstruction of the airway on that left side, then obviously that can relate to a breathing and airway disorder. Is the upper airway restricted so it's forcing the patient to breathe through their mouth, dirty air back against the tonsils, inflaming, enlarging, infecting the tonsils, and leading into more and more breathing and airway problems. Another thing we can look at is skeletal profile. So Dr. Bill Arnett out in California, Santa Barbara, developed a profile analysis. He calls this true vertical line drawn from the selenasion straight down. And what we want to see is the upper lip, as the patient's looking to the right, is the upper lip on the photograph, or as you view them, 2 to 5 millimeters to the right of that line. The lower lip, 0 to 3 millimeters to the right of that line, and the chin, 0 to 4 millimeters behind the line. If you see a situation like this, then you're looking at not only mandibular deficiency, but you're also looking at a maxillary deficiency. And so that can be very important. With a maxillary retrusion situation, often you'll get into a Mallampati type 4 because of the fact that the soft palate's having to drop down the back of the throat because there's no room for it. And so here's how we'll evaluate that. Screening is simple. Evaluation is simple. Are there any red flags, positive signs of airway or breathing disorders? If so, we would consider overnight pulse oximetry, which you can do, home sleep testing, which you also can do, to find out exactly what's going on with oxygen saturation, heart rate, these sorts of things. And then from that, we're going to develop diagnosis of whether they're negative or positive for a breathing and airway problem. If they're positive, then we're going to go through 2 phases of management, and this is all evolving right now. It's so exciting to be part of this, as we're going to have a management phase, much like we do with TMD disorders. So let's say someone comes in with sore muscles and joints. We may put a splint in to see if we can resolve the problem, to get them stable before we go on to any definitive occlusal therapy. The same is true with airway and breathing problems. We'll do some preliminary things. One of those things would be to try to get them breathing through their nose properly. So this book, The Oxygen Advantage by Patrick McKeon, is an excellent book to read, and I have patients reading it all the time as well, training them how to breathe through their nose. Sometimes we'll do taping of the mouth to encourage nasal breathing as long as the upper airway is open. At nighttime, they'll tape. Or we'll train them through these methods called Buteyko training methods of proper nasal breathing, proper diaphragmatic breathing, keeping the mouth closed literally all day. Once we work through more management protocols, here Keith Thornton from the TAP organization in Dallas, Texas, has developed a trial oral appliance that you could use for both TMD problems as well as airway, whereby you open the vertical, you keep the mouth closed, you can adjust it both horizontally and vertically to see what kind of results we get using an appliance. But it's a trial appliance, very inexpensive, very simple to use, a great way to see what kind of results we get and how we would consider moving forward. And so that, along with sleep position, weight loss, at times appropriately working with a sleep physician, would be a phase 1 strategy. Then phase 2 would be more of a resolution phase, where we're trying to reverse the problem of breathing, reverse the problem of airway obstruction. So we're thinking now, let me go back, we're thinking now about things like expanding the dental arches. A lot of restorative dentists now are engaging in Invisalign type therapy as a phase of correction of malocclusions, but also to help with airway problems. Tongue tie releases. There are a lot of dentists now that are doing tongue tie releases if they get the proper training and are having great results, even working with newborns. Expanding the oral airway, expanding the upper airway, expanding the posterior airway, expanding the arches in the room or the box that the tongue sits in. Let me give you an example of this, just as we're trying to get you warmed up to this concept of evaluating airway problems, but also how it overlaps with TMD problems and complete care. So here's Danny. He's one of our students at the Dawson Academy that is from Sydney, Australia. Danny was recently in Florida for courses and asked if I would evaluate him because he was having some concerns. And so he came into the office with this complaint. I have frequent headaches in the morning. I'm aware of clenching my teeth daytime and nighttime. My jaw's sore, my neck is uncomfortable, my joint on the left side sometimes clicks, my bite feels off, I see some crowding of my teeth and a little bit of wear on the incisal edges of my anteriors, and I have constant nasal congestion, so I'm using nasal sprays quite a bit. And here was his question: do I need a bite adjustment or do I need ortho? In other words, those are the two options, correct? And so let's take a closer look now with hopefully new eyes at Danny. So here's Danny's teeth, just looking anteriorly, and what do you see? You see some crowding. So crowding arches, very common with people that are mouth breathers, crowding of the arches. We look at his profile and you can see that he has a maxillomandibular retrusion. So his maxilla is back in the posterior part of his mouth and airway. When he opens wide, you can see that he has a scalloped tongue. When you look more closely in the back of his throat, you can see that he has huge tonsils and minimal airway present in his mouth. Also, when he opens his mouth wide and you say, raise your tongue to the roof of your mouth, Danny, he can only go about 40%. So he has a severe tongue tie restriction, and that obviously affects function and creates dysfunction. And so we get a CT on Danny, and what do we find? We see obstruction in the nasal cavity, but I want you to look at this. This is the worst case I've ever seen in my career. I've just outlined the tonsillar tissues, and they're literally what the physicians call kissing tonsils. But look, as I outline in red, the airway in the back of his throat. That's the full diameter of his posterior airway. I mean, it's like a coffee straw that he's trying to breathe through constantly, day and night, that's creating all kinds of sympathetic response, cortisol release, stress in his whole body, including his facial musculatures, including around the temporomandibular joints, and makes a lot of sense that he would be having struggles. Does he have upper airway resistance syndrome? It most likely is. And so then as we look at this, watch this, and I want you to see how these things overlap with each other. This is fantastic information and so critically important to where we're headed in the future of dental medicine. When we look at infection and inflammation, Danny has swollen tonsils, certainly a sign of inflammation, if not also infection. When we look at his airway and breathing, he's a mouth breather. He snores. He has poor sleep quality, nasal congestion, forward head posture, tongue tie. He has a deviated septum. His Mallampati is greater than 2. He has a scalloped tongue, 40% tongue restriction. We're going to recommend an overnight study for him for sure as a starting place for analysis for his overall system. But I want you to see the overlap now with TMD and occlusal problems, because he also has joint discomfort. He also has popping and clicking, sore muscles, some bruxism, poor bite, aware of clenching, slight wear on anterior teeth, crooked teeth, muscle palpation, soreness, and his relationship between his seated bite, his seated joint and his seated bite has a hit and slide or discrepancy. We listen with the Doppler, and there's some mild crepitus and clicking in one joint. And so we do imaging, and you see even more there that's important. So if we're asking from our checklist, does he have any problems in these areas, it would be, yes, there are signs of infection and inflammation. Yes, there's signs of airway and breathing disorders. Yes, there's signs of TMD and occlusal disorder. And so we'll flip the page and follow our checklist and say, well, now what do we do for Danny? And so here we're going to think about, from the airway and breathing perspective, in the initial management phase, we could work with breathing exercises. We know he's very obstructed, and so the amount of improvement we're going to find, we don't know. So we can train him on proper nasal breathing. We could experiment, as long as he can breathe through his nose, of taping and increasing the nitric oxide release and a lot of the good things that happen from nasal breathing. Allergy testing would be right up front with Danny. Are allergies driving this inflammation, obstruction, and blockage? Maybe that's the key to everything, perhaps. And so we don't want to forget that, so we've got it on the checklist, so we're not going to miss that. We can working with trying to make improvements in his airway by working with an interim appliance. We could use a MyTap and try to increase his vertical, maybe shift his horizontal. Is that going to make any difference to his airway? Well, maybe, but we could work with a simple trial appliance, very inexpensive, but very therapeutic and diagnostic for us to help see if that'll help. And then resolution protocol. So we're headed in that direction, maybe very quickly with Danny, expanding the oral airway, expanding the upper airway, expanding the posterior airway, opening up these blockages, releasing the tongue tie. So we're going to need to work with an ENT about Danny's airway. We're going to be considering orthodontic expansion, whether it's in our office or with referral, and also tongue tie release, whether in our office or referral. These are going to be things on our checklist to do for Danny, and then ultimately that will lead to our definitive solution, hopefully, of resolving his problems, not just wearing an oral appliance for the rest of his life, but actually trying to open up the airway and his breathing and retraining that so that he doesn't have this problem for the rest of his life. So again, I want to note, and I hope that you're getting the picture here and you're starting to get excited about the future of dentistry, because we're going to be on the front line solving these problems like no other specialty in medicine in the very, very near future, meaning starting now. And that is, we understand that systemic inflammation and infection, we understand that breathing and airway disorders, we understand that TMD and occlusal disorders can be connected, can be related, they can overlap and exacerbate each other, and we need to be aware of all of these. So my belief today is that we're entering a whole new generation, and I'm just talking about airway right now, but also with inflammation, infection, TMD, and occlusion, that we're adding a whole new frontier to the future of dentistry, which is what I'm calling dentistry's great awakening. Our eyes are open. We're thinking about sleep apnea, yes, but it's much, much more than that as we think about our great awakening. And I want to share a quote with you by a very respected colleague, Dr. Tom Colquitt, who was the president of the American Academy of Restorative Dentistry, a very prestigious group, very elite, small group of top-notch clinicians. And at the 2016 meeting of this Restorative Academy, this was a statement that Tom Colquitt made that I have had stuck in my mind ever since, and that was this: there are new priorities for us in dentistry. Number one, that other than emergency care, the first procedure performed by every dentist for every patient of any age should be a proper airway examination and evaluation for breathing function. And that secondly, the primary duty of every dentist is to promote proper nasodiaphragmatic breathing for every single patient. And then thirdly, not because of being unimportant, but because of prioritizing medically, the teeth should be of secondary or second phase importance. And so this is a powerful statement, I think, and really something that has influenced me greatly. So what I'd like to do in our group together is to take a few minutes now, and I would like to discuss what are the implications of this session on airway and breathing disorders for the future of complete dentistry as we're discussing it together in the Dawson Academy. For complete dentistry, what are the implications of this as being a frontier, a next step, the next generation, the next era to incorporate into our complete dentistry model? So let's get together and talk about that for a few minutes.